Okay. 3.
Good afternoon. This is Cynthia Kanaki with the ALS Association. I want to welcome you and thank you for carving time today to join us. This webinar is one of a series of monthly webinars focused on bringing information of a practical nature to those living with ALS. Today, we are pleased to share information about the features and benefits of ALS Multidisciplinary. For your convenience, the webinar and the associated slide deck are recorded and posted to the ALS Association website for post-live presentation viewing. Please give us about 24 hours to get that posted. Before I introduce our guest speaker, let me invite you to participate in our webinar by posting comments or questions to the question box. I may be able to answer your question privately, especially if it's of a technical nature, or I can share your question or comment with our audience during the Q&A session. So let me introduce today's speaker. Dr. Tabor Gray holds a master's degree in speech-language pathology and a doctoral degree in rehabilitation science. She is associate professor at Nova Southeastern University and co-director of the ALS Clinic at Nova Southeastern University Neuroscience Institute. Please join with me in a warm welcome for Dr. Tabor Gray. Dr. Tabor Gray, I believe you have your slides available, so I will stop sharing and allow you to share your screen.
Thank you so much for that introduction. All right, and with that, I will get started here. Can we see my slides okay?
Yes, ma'am.
Okay, great. Thanks for that introduction, Cynthia. I'm excited to be here, and thank you all for taking some time out of your day to have a discussion with us over the next 45 minutes or so. As Cynthia mentioned, I am now the co-director of the Nova Southeastern Health ALS Clinic. This is a recently opened clinic just last year, but that is not the beginning of my ALS journey. I've worked in multiple ALS clinics in the state of Florida, including the University of South Florida, the University of Florida, and the Holy Cross Clinic in Fort Lauderdale as well. So today I bring a lot of real world experience in trying to optimize the care within the multidisciplinary ALS clinic setting, and all that entails for our patients, their caregivers, families, as well as the providers. And please, if you have any questions, as Cynthia mentioned, insert them then into the chat box so we can have a little bit of an interactive discussion after the slides. All right. So a very brief introduction, and no one on this call is a stranger to this disease at all, unfortunately. But amyotrophic lateral sclerosis, A meaning no, myo meaning muscle, trophic meaning nourishment. So we have no muscle nourishment. The location of the disease is in the area of nerve cells affected by both upper and lower motor neurons, which presents our symptoms of spasticity and weakness. And then we have sclerosis or hardening that occurs as the motor neurons degenerate. And the pathology of the disease, and I give this background really to provide a context as to why these multiple different providers are important in multidisciplinary care, because this disease, as you all know, affects us systemically, with upper motor neurons affecting the cortical motor neurons and bulbar and spinal tracts, as well as the lower motor neurons. And these manifestations that we see from a physiological standpoint result in what we see clinically, and that's spasticity. We see this as muscle stiffness, muscle slowness, hyperreflexia, and decreased speed in our motor movements. And this affects things like walking, moving our arms, breathing, swallowing, speech. And then from a bulbar palsy standpoint, this results in clinical symptoms of atrophy. And we see this in clinic as flaccid paresis, decreased strength, decreased force, and fasciculations. And we see these fasciculations kind of all over the arms and legs, sometimes in the muscles of the tongue, and they affect our ability to move quickly and accurately. So with all of that affecting kind of the arms and legs, muscles of breathing, speech, and swallowing, you require a lot of providers to address each one of these concerns in a way that is preventative and not reactive, and a way that keeps everyone safe. So in our ALS clinic, we see kind of the continuum of different motor neuron diseases. We have ALS, which we presents as both spinal and bulbar onset, affecting the muscles of the arms and legs first, or affecting the muscles of speech and swallowing. We also have primary muscle atrophy, which is predominantly lower motor neuron, so a lot of that weakness, and primary lateral sclerosis, which is even more rare than ALS and is upper motor neuron predominant, so a lot of spasticity and reduced speed in this particular disease. So the primary point of today's webinar is to really discuss what evidence-based care looks like for patients with ALS. And we know this is to be, evidence-based and kind of borne out in the literature as well, that interdisciplinary and collaborative care results in the best possible outcomes. So here we have a schematic with all these different medical providers, with the person with ALS as well as their patient, as well as their caregiver in the center. And in these clinics, we really focus on patients as partners, with the idea being that, we do the evaluations, we provide a lot of education, but your wishes and your quality of life and your expectations are really what drives this kind of precision, individualized medicine approach. Including friends, family, and caregivers is always best. The support system is imperative in this type of disease. Primary care doctors to either write the referrals or follow through on orders outside of the clinic. Collaborating with hospitals, emergency rooms, palliative care, and hospice. And then anything that we recommend in clinic, of course, we want to be carried out in the home and outpatient therapy. So writing plans of care, faxing orders, sending orders, working collaboratively with home health agencies to make sure therapies are not only appropriately carried out, but that the goals are what we want to see for our pals and their caregivers. So the primary mission in these multidisciplinary clinics is, number one, to run the multidisciplinary clinic with the appropriate providers that were just in that previous schematic, to offer telehealth appointments. And this is something that really exploded for us during COVID. We had a lot of resources that were piled on from a Zoom standpoint and making everything, compliant in terms of healthcare information, to make sure that we can make these multidisciplinary telehealth appointments accessible to patients, not only because of COVID restrictions, but also because of if they live in a rural area, if they have advanced stage disease and travel is really difficult. COVID was really a catalyst to offer a lot of telehealth resources that we did not previously have in place. The comprehensive care involves mobilizing community resources. This includes our partnership with the ALS Association or Motor Disease Association, and local organizations like Always for ALS, which we frequently work with. And that's in addition to advocacy. So we have clinical research opportunities. The ALS Association is wonderful at funding a lot of our research, as well as ALS Therapy Development Institute, or TDI, working on legislation to help fund state legislation for our clinics, as well as federal legislation for our research programs, as well as patient ambassador programs like the Curly program, which is offered by Dr. Richard Bedlack at the NEALS, Northeastern ALS Consortium, every year. So again, your care team, and I'll kind of go systematically through what each discipline is responsible for, how the evaluation looks, and how we all work together. So when you come in for your visits, these are the individuals that you'll see if you go to an ALS Association, either affiliated or a certified treatment center of excellence. And the goals during each clinic visit are to manage your symptoms, whatever they may be on that particular day or time period, maintain quality of life, reduce the burden of caregivers as much as possible, to coordinate all these different disciplines in their care, and to provide research opportunities, whether it be observational research, biobanking, interventional clinical trials, behavioral interventions. There's all different types of research opportunities that can be offered at the multidisciplinary clinic. And the hope is that by doing all of these 5 things I just mentioned, we can slow the disease progression and ultimately, reduce the amount of symptoms or hospitalizations or infections because of these symptoms that you're experiencing. So the impact on life and function, and the reason that we have these multidisciplinary clinics is because, as you can see, ALS can impact a lot of different things: breathing, swallowing, quality of life, cognition. This goes to things like emotional burden due to the nature of the disease, or there's the association with frontotemporal dementia. So you can also have issues with memory or long-term or processing, and those are all things that we can evaluate in the clinic. Mobility, so that's walking as well as moving your arms, being able to feed yourself, as well as communication. So if you have bulbar onset, the muscles of speech and swallowing are impacted, and that can make communication, verbal communication, very difficult. So it's important to evaluate kind of alternative options if verbal communication is no longer a feasible avenue. And with all of this, as providers, we are well aware of the fact that this is an incredibly overwhelming amount of information that we provide in clinic. Typically you're visiting with all these different providers for 20 to 30 minutes. So it's a lot of information in a short period of time. And we do things like provide written patient and caregiver education, written orders, communicate via email, try to follow up as much as possible in order to break down this information in a tangible and digestible way. Okay, so there are a few important disease characteristics when you come to clinic that we evaluate because we know they influence care. This is not an extensive list, but these are things that we pay a close attention to, particularly during a first visit, and then again during each 3 to 6 month visit. So this is onset type. That goes back to the bulbar or spinal, whether your speech and swallowing muscles were affected first, or whether the muscles of your arms and legs seem to be the first body part affected. Body mass index. So this is predominantly based on a calculation on your height and weight. And we know that drastic drops in weight are associated with progression of the disease. And this is something that we can easily evaluate and pay close attention to over time. The degree of respiratory involvement, and that's at onset. So we do measures of vital capacity, which is how much volume of air you can hold in your lung, as well as measurements of pressure. And that tells us how well your diaphragm is working, which is a really important muscle in ventilation, as well as the family history. So more recently, we know that ALS or motor neuron disease have a 10%, potentially more than that, related to a family history of ALS, psychiatric disease, or dementia. So we pay close attention to this. And in our clinic in particular, we do genetic testing on all of our patients. And I think that's becoming more of a widespread approach. And one of the main questions that we get when patients come in for a good reason is, how quickly is my disease going to progress? And our neurologist in our clinic uses a model to try to track that as closely as possible. So, and I'm just going to give you a few examples here. We can pay close attention to some of the things I just said, like how quickly they're progressing, the degree of respiratory involvement, which is seen here as a forced vital capacity, whether or not there's dementia or a familial factor, which is C9, and the location of onset, which in this case is bulbar. So if we input all of these factors into a model, we can get a general idea, if there's no intervention, how quickly a patient will progress. So the blue line is the patient that data was entered in the model, and the dotted line is the average patient. And this is by no means set in stone, because we have quite a few things that we can do now in ALS, whether it be alternative off-label treatments or clinical trials, or some of the recently approved drug treatments, as well as behavioral treatments, to try to move this line in a more favorable fashion. But it gives us a good idea of what we need to pay close attention to kind of moving forward. And this looks a little differently. Someone with a much higher vital capacity, with an absent frontotemporal dementia or familial factor. And you see here that this current patient has a much longer expected lifespan. But again, these things can be potentially changed based on the interventions that could be offered at a multidisciplinary clinic. So a day in an ALS clinic. The goals for a single day in clinic are to assess physical function. So this is a head to toe assessment. see how everyone is doing, including the family and caregivers in terms of quality of life, manage the symptoms that you're experiencing, and address any disease-related complications. And a secondary goal is to empower patients and caregivers through open discussions regarding care, future care planning, and opportunities for research participation. And logistically, this looks like a visit to our clinic or any certified treatment center through every 3 to 6 months, depending on the nature of the disease progression, how close you live. In Florida, we have a lot of snowbirds, so sometimes we only see patients once every 6 months, depending on how often they're in Florida. But ideally, really, for us, it's every 3 months. And these visits last about 3.5 hours to see multiple different providers. So returning to this schematic here, we have the neurologist, a liaison from the ALS Association, and a social worker, a speech-language pathologist, a dietitian, occupational and physical therapy, which often evaluate the patient together, a respiratory therapist, a mental health professional, which in our clinic is a neuropsychologist, but it might vary depending on the clinic, and a nursing professional, which might be a registered nurse or a nurse practitioner or a doctorate of nursing. So when you see the physician, this is a person that you've probably seen before your day in clinic. At least that's how we do it. So this will be a secondary visit with a neurologist who either has diagnosed the patient with ALS or they've been previously diagnosed. And the physician will do, a head to toe assessment of reflexes and strength. This includes muscle twitching, cramping, strength, and they're able to provide a diagnosis, an overall disease diagnosis, but also a diagnosis of the severity of cramping, strength, and loss of reflexes. A head to toe evaluation, he or she puts the pieces of the puzzle together from all the different providers and makes recommendations based on medication management and home therapies. They may discuss alternative and off-label treatments, and they're absolutely involved in advanced care planning with the entire team. This includes things like, how much information do you want to know about your disease progression? Are you interested in clinical trials or things that may slow the progression of the disease? And these are wishes that are different across every patient, so they're really important for us to have upfront and often because, of course, they change. So supplements and alternative off-label treatments, we always defer to Dr. Rick Bedlack. He is the brains behind ALS Untangled. So we use this resource as well as providers to kind of identify the literature behind some of these alternative and off-label treatments, and it's open to patients as well. It's an excellent resource, and you can bring this, to discuss with your care team and care providers to see if it's something that you want to explore a little bit further. Respiratory management is done by the respiratory therapists with a primary goal of improving ventilation. So the primary treatment for shortness of breath or reductions in measurements of vital capacity, which is that measurement where they ask you to breathe in as much as you can and then blow out for as long as you can. That's a measure of non-invasive volume ventilation. And the primary goal here is to reduce the amount of CO2 that you're retaining. So that's the primary, if you're waking up with morning headaches or you're finding it difficult to breathe when you lie flat, non-invasive volume ventilation might be something that's really beneficial to help with those symptoms. And there's all different types of face masks that can be worn with this particular device to help improve ventilation. With research telling us, more and more that early management of these symptoms is better for survival and better for overall respiratory function. So it's something that needs to be closely evaluated and often. Respiratory management can also involve improving a weak cough and aiding in managing of secretions. So if you feel like you have a lot of secretions in your upper airway or in your throat, use of a cough assist device or an oral suction can be really helpful. With cough augmentation, it's not something that we recommend that's done, when you feel like you need it. It's kind of like an exercise protocol. So imagine you are given this machine to take your lungs to the gym, and every day you do a treatment protocol 3 times, and each time you put it on, you do 3 to 5 coughs. So it's just like exercising any other muscles. It's really important to keep the muscles that surround your lungs healthy so that we can try to ward off any respiratory infections. And we get a lot of questions about invasive ventilation. So if the breathing equipment that has the masks and the tubes doesn't work anymore, or you have to wear it 24 hours a day, is there another option for improving ventilation? And there is. This is respiratory support that we can use when non-invasive volume ventilation is no longer supportive, or if you have an unmanageable amount of secretions. So this is a breathing tube that's placed directly in the throat. So you're bypassing the mouth altogether. So no more masks on the mouth or around the nose. This breathing tube goes directly into the trachea, which leads down to the lungs. And you're on the ventilator 24/7, but you no longer have to use a mask. This is an extensive discussion that can be had at multiple times throughout your care. You can discuss a tracheostomy when you get the regular breathing equipment or beforehand, or if it's something that you don't want to do. We have this discussion, these kind of patient education sessions to learn about what a tracheostomy is and what functions change as a result of these breathing tubes and breathing equipment. And it's definitely something that should not be taken lightly, but we're happy to have these discussions to talk as much about tracheostomies as the patient and their caregivers want. The speech language pathologist, or SLP, also evaluates swallowing and communication. From a swallowing standpoint, our swallowing or esophagus, our food pipe, is very closely placed to our airway. So we work very closely with the respiratory therapist to manage airway protection and to try to improve cough. So typically when we have something go down the wrong pipe, we can cough it out. But we know in ALS, the ability to cough is severely impaired. So we really try to focus on improving or maintaining cough function really early in the disease. And I have here, if you've ever been recommended to do a modified barium swallow study, this is kind of our gold standard way of evaluating swallowing function. And here on the left, you see an individual swallowing a bite of pudding, and you see it happens really fast in about a second. And you'll notice everything goes down the back tube, which is our food pipe, and the front tube, which is our airway, stays clear. And as swallowing starts to change, you may feel like you have food hanging up in the throat. So here we have some residue, we call, hanging up in the throat after the swallow. And this starts to happen as the muscles get a little bit weaker. So you might take another dry swallow, you might swallow a little bit of liquid, but these are changes that we really like to capture as the disease progresses so that we can make some recommendations to avoid swallowing related fatigue and make sure that you are safe and efficient in your ability to swallow food and liquid and protect your airway. So that's the job of the SLP. And when we talk about swallowing and breathing and the relationship between the SLP and the respiratory therapist, in our clinic, we work closely with airway clearance and cough augmentation early interventions. So the devices that I showed you earlier are typically recommended once impairments in airway clearance are already apparent. So we started using this piece of equipment. This is an expiratory muscle strength trainer in order to improve airway protection or the ability to clear the airway if something went down the wrong pipe. And here we have a case study in one individual with ALS who did a sham training. So that's basically they blew into a tube with no resistance for 8 weeks. And then we had them blow into an actual expiratory muscle strength trainer at a good bit of resistance. And we found a lot of improvements in this measure of expiratory pressure generation. So that's really just a measure of how quickly and how much pressure you can generate on the exhale as we do during a cough. So we know that if we intervene early, we have the ability to improve one's ability to clear their airway or develop a stronger cough. And that's something that we do in our clinic early on. So this is one example of an early respiratory intervention. In addition to swallowing and airway clearance, the speech language pathologist evaluates communication. And our patients often say that one of the first things they notice is they start to talk less. Their speech is slower, they have more difficulty, it makes them more short of breath. So they start to withdraw a little bit during communication, and kind of, if they were going to say a story or going to tell a joke, they kind of choose not to, because either it's too fatiguing, too tedious, or their speech is too slow and they miss the opportunity. So that's really something that we try to avoid, or try to find an alternative method of communication that they can at least maintain the ability to tell those stories. And the first thing that we talk about is voice preservation. And this is things like voice and message banking and the use of compensatory strategies to conserve energy and kind of prolong the endurance that someone can have during a conversation. So we do this through things like voice amplifiers. And then once or if verbal communication is more involved, we talk about low-tech and high-tech communication strategies, which I could spend an hour talking about in and of itself. I will leave it at that, but there are certainly more to be learned in terms of how we can evaluate communication and how we can offer communication options once verbal communication has become impaired. The dietitian is primarily responsible for nutrition support and management. Like I said earlier, body mass index we know is an indicator of hastened or quickened disease progression. So have a really important job of providing a lot of patient education and recommendations for avoiding weight loss and making sure that we're well nourished and well hydrated. If eating by mouth, it becomes really difficult, or the patient can't maintain their weight by eating alone, we can talk about feeding tube placement. This is typically done, the evidence-based guidelines we have now is that the feeding tube placement is done before the vital capacity drops below 50% and before someone loses greater than 10% of their body weight. So those are recommendations that we try to follow because it's an indicator of a better outcome in terms of survival. And the dietitian has a very difficult task of making sure that all of those checks and balances are taken care of during the multidisciplinary clinic visit. The physical and occupational therapists often go in together. They do in our clinic just because their evaluations are so similar. So they're looking at upper extremity mobility. So that's shoulders, arms, forearms, hands, fingers, providing recommendations for some potentially helpful durable medical equipment. So here we have a soft resting hand splint, which can help if the fingers are kind of contracted or tightened. It can help lay them out flat in a nice non-painful position. We have a rolling walker, an AFO, which is something that helps with foot drop to prevent falls. We have a bed cane over here on the right that assists with getting out of bed, some adapted utensils to help with self-feeding, and then a power wheelchair. If ambulation or walking no longer is safe, we can recommend a power wheelchair evaluation to see if that is an appropriate recommendation moving forward. So physical and occupational therapy, very important for recommending durable medical equipment, talking about home exercise programs, and of course, fall prevention. The social worker and the ALS liaison, they are what I call the resource gurus. They always know everything from insurance, what's likely to be approved for particular insurance agencies and what's not, how home health is going to be dictated for specific insurances, and what the best way to obtain certain durable medical equipment is. So we take advantage of the ALS Association loaner closet a lot. We have some local organizations with loaner closets of their own. And this is just a wealth of information, including the 5 wishes. So this is a way to kind of lay out exactly what you as a patient and caregiver want to do in terms of medical decision-making. And if you have a healthcare surrogate or a power of attorney, our social worker discusses these options with patients and their caregivers. And importantly, they also sign patients up for the ALS Association registry, which is something that we try to get all of our patients registered for so that they can take advantage of resources from the loaner closet and get information about webinars and patient and caregiver support groups to try to keep them in touch with resources and as well as other patients. The neuropsychologist in our clinic, this is the mental health professional in other clinic. It's not always a neuropsychologist. But they're responsible for addressing the emotional, cognitive, quality of life issues that arise when confronting the challenges of living with this disease. So it can be things like apathetic. So maybe you're noticing you're withdrawn or less interested in life in general. The anxiety that comes with the progression of symptoms or the anticipation of progression of symptoms. A lot of patients experience a lot of depression or bouts of depression when dealing with changes in or loss of independence. And then in some aspects, there are changes in behavior, and this can be tied in with a diagnosis of frontotemporal dementia or symptoms of frontotemporal dementia with changes in behavior as well. So the neuropsychologist will evaluate kind of mental well-being and refer for a full neuropsychological evaluation if they think it's necessary. Palliative care, I think, is so important in any clinic. It really provides an extra layer of support and care throughout the duration of the disease. And I think it has a real stigma associated with it in most cases because it's often linked with hospice. So I think this graph is a nice way of looking at palliative care because we really recommend it at any stage throughout the disease. They can provide eyes in the home, so they can do home evaluations with a primary care physician and kind of communicate with the clinic as to how you're doing. And then when and if hospice is important, they really have a very good relationship with hospice organizations and can give you recommendations or just talk about it or provide a lot of resources for you to explore when you feel like it's appropriate. So I thought this was just a nice schematic provided by Vitas Healthcare, which is one of the palliative and hospice organizations that we use. So again, palliative at any stage of the disease, and hospice, the medical definition is a prognosis of 6 months or less. So in common, they provide comfort care, can reduce stress, offer complex symptom relief related to ALS, and physical and psychosocial relief. So again, palliative at any stage of the disease, it's something that we really have appreciated in our clinic and hope that most patients have access to it if they want. So overall, the best management is a team approach. We're looking at symptoms with pharmacological management, respiratory intervention, speech and swallowing, nutrition, and mobility. Trying to mitigate or slow the progression of the disease using FDA-approved medications, as well as alternative off-label treatments. We have a lot of experimental drugs that are in clinical trials and providing patient and caregiver education. Improving quality of life is also a crucial kind of pillar of best management. And this involves life planning, individualizing our care to the goals of the patient and their caregiver, making sure that there's access to mental health counseling, providing resources to help, and engaging in support groups. And finally, when trying to reduce caregiver burden, this also involves life planning, and it involved in things like advanced directives, access to support groups for caregivers, and mental health counseling for caregivers as well. So this is just a summary slide to kind of provide everyone that we just went over and their primary responsibilities or roles when you come to clinic. So it's nice when you do have a clinic appointment and you have questions written down or questions in your phone notepad. You can kind of guide your questions to the appropriate care professional during your clinic appointment based on these roles and responsibilities. And then lastly, and certainly not least important, but clinical research opportunities are really an imperative pillar of care in ALS, particularly because we have no cure. So research is our ability to empower patients and their caregivers and give them an opportunity to participate in research if they would like to. These can be interventional research. So this would be when you're offered a drug or a therapy or, respiratory training to try to improve an outcome, like slow the progression of the disease or improve speech or improve cough. That would be an interventional trial. There are also observational trials. These are things like you come to clinic once every 3 months and we collect these different outcome measures. And these trials are often used to identify targets for therapy in the future or identify things that need to be addressed. So for instance, in our clinic, we're doing a study looking at caregiver burden and how it evolves over time. So every time our patients and their caregivers return to clinic, the caregivers fill out a few surveys and provide us their input on how they're doing. And this ultimately is going to give us the ability to create resources for caregivers to help them along this journey. So that's an observational trial. And then one other type of research is biobanking. This is things like you come to clinic once or several times and you donate things like blood or urine or cerebrospinal fluid. And this is helpful in, really the biological part of ALS. So trying to find different biomarkers that might be associated with disease progression or different biomarkers that we can target for drug development. And so biobanking is another aspect of clinical research opportunities. So overall, the goals for exceptional multidisciplinary care, that the care is comprehensive and coordinated, involving family, caregivers, friends, and the ALS Clinic team. That the care is proactive as much as possible versus reactive. So we'd like to optimize symptom management, conserve energy early on, talk about difficult things such as feeding tube placement or placement of tracheostomy, or whether or not you want to participate in clinical trials. We like to talk about these things early and give you the ability to, of course, change your mind as things go, and to provide a lot of patient and caregiver education to prevent things like falls, pneumonia, hospitalizations. So we're trying to be as proactive as we can in our interventions. And lastly, to provide the opportunity to participate in experimental research, clinical trials, observational studies, or biobanking. Thank you very much for your time. And all of the resources listed here, I have no affiliation with at all, but I find them to be great resources for patients and caregivers when you need to learn more information about clinical trials or learn about ALS conferences or potential caregiver and patient support groups. There are a lot of excellent resources out there at your disposal that are free to use and fairly easy accessible.
Well, thank you, Dr. Tabor Gray. That was fabulous. I really appreciate the overview you gave. It was very easy to follow along both the features and each of the benefits of those features in a multidisciplinary care model. A couple of questions have come across my desk, and first of all, I thank you so much. Research is top of mind for many people living with ALS. So I really appreciate you reviewing the range of research options that are available. And one of the questions was related to research. Someone asked, I don't qualify for my clinic's research project. Can I get into a research project managed by a different clinic? It's twice as far, but we can drive.
Yes, you absolutely can. We have a lot of patients that drive to our clinic for the opportunity to participate in research, but are actually seen in a multidisciplinary clinic elsewhere because it's closer to their home, or they like the team better, whatever the reason may be. You have the ability to participate in clinical research wherever you qualify. So absolutely travel if you have the means and interest. I would highly recommend that.
Wonderful, wonderful. Thanks very much. Another question about telehealth. You mentioned that early in your presentation. The question is telehealth an option for any of our quarterly visits or only early on?
So this is an answer that's going to differ across multidisciplinary clinics. In our clinic, we offer the opportunity for telehealth as after your first appointment. So as long as we've had one face-to-face appointment with you, you can do telehealth, at the follow-up appointments. It's not ideal because there are a lot of measures that we can't take via telehealth, like the breathing measures, the swallowing measures. You know, we have surrogate measures that stand in for, you know, some of the more objective stuff that we need, but face-to-face clinic visits are ideal. But if you can intersperse them, so maybe you do a face-to-face visit and then a telehealth and then a face-to-face and then a telehealth, that can also work, particularly if the travel is really burdensome and it's difficult to get to the clinic that you need to get to. But I will say that telehealth is not offered at all clinics. So it's something that unfortunately is not a standard of care yet.
Well, you mentioned early on that came upon the scene pretty much once the COVID environment began to unfold, and that turned into a bit of a silver lining for people that were either not able to travel or the clinics were more limited. So certainly a valuable option depending on what your situation is. And another question came in about apparently an early diagnosis. My local neurologist referred me to an ALS specialist at the university to confirm my disease. Can my ALS be managed by my own neurologist, or do I have to see a specialist at the university for all my visits?
That's a great question. I would recommend going to wherever you have a multidisciplinary clinic. We have patients that have been managed by a single provider, but it's incredibly difficult for a single provider to do the work of, 12 different disciplines. It's a lot to ask of that provider, and unless they have a really good network of therapists and healthcare providers, it's really something that's best managed by a multidisciplinary team. So I would say go where that team is, whether it's the university or the neurologist that you have outside of the university. I don't think that matters. I just think it matters that they have a team behind them.
Great, thanks very much. Now, another question that's kind of on the coattails of this. Will I be seeing every single specialist during my visit, or only the ones related to my problems, like walking but not breathing?
So if you go to an ALS certified treatment center of excellence or an affiliated clinic, you will be seen by every provider, regardless of whether or not you perceive to have symptoms of that provider. Some clinics are run by different organizations and they don't require to be seen by every discipline. So for example, like you were saying, if you only have difficulty walking, maybe you would go in, be seen by the neurologist, the physical and occupational therapist, and that would be your appointment. In our clinic, you're seen by every discipline at every visit. And our rationale for that is sometimes you don't know that you're having problems until someone evaluates you and finds out you're having problems. So for example, we have patients that say, I don't have any problems coughing. If something goes down the wrong pipe, I can cough it right back up again. And then we test the strength of their cough and it's 50% of what it should be. So it should be 500 and it's 250. And that's not something that they perceive to change, but it's something that when we can objectively measure it, we know it's changed. And the only way for us to intervene proactively and early is if we measure these things, regardless of whether or not the person thinks they've changed. Because if we wait till you have problems, it loses us a crucial window of opportunity to intervene with things like the breathing treatments and drugs that are shown to work early in the disease when breathing is not a problem. So that's why we evaluate everybody regardless of whether or not you think you have symptoms in that particular domain.
Actually, I'm glad that that question was shared, because several of your slides you shared with us the different trajectory that people have. I mean, not everyone's disease unfolds at the same rate or in the same manner. And it seems like it certainly is helpful to at least have all those different disciplines available so that things can be measured on a quarterly or kind of standardized basis, and then you could pick up when things are changing.
Yeah,
I know quite a lot. Yes, continue.
Sorry, a lot of what we do is very, is proactive. So for example, as a speech language pathologist, we focus on voice preservation. These are things like voice and message making. So I need someone to have almost little to no difficulty in their speech in order to do the voice recordings and the message recordings to save for later. So if we wait until speech is really impaired before I start seeing them, then it creates an issue with the opportunity for voice banking. We lose that window.
Quite helpful, yes. And you did mention that there were a range of things that are available for symptom management, for example, that can address some of the challenges people may have.
Exactly. So you may see, yeah, go ahead. I'm finished. Go ahead.
People have also reported that they're surprised sometimes when they have a measurement at clinic, like a respiratory measurement, because their breathing has changed pretty slowly over the weeks or days, and it's not something that they recognize. And then when they had a breathing test, they were surprised at the results. So could you speak to that as far as why it's helpful or important to have these measurements done routinely?
Yeah, absolutely. That is definitely something we see. So, some patients have symptoms that progress really quickly, and they are more aware of their changes in breathing. But we have some patients who, symptoms started in their left leg in 2020 and they perceive no breathing, but we're in 2021 and we assess the breathing and it's down to 75%, which, it's typically 100% of predicted and it's down to 75. Still very functional. They can still, walk around and exercise if they want to. But while they're not symptomatic, that's great that they're not symptomatic. But the point is that gives that 75%, we can still intervene. We can do early intervention, lung volume recruitment and respiratory muscle strength training to try to stay at 75%. We don't want to wait until things are 50% before we intervene. So we like to do the breathing assessments every 3 to 6 months or however often the appointment is. And best case scenario, it's staying the same. And that's great.
Great, wonderful. Here's a comment, really not a question, but a comment. I have ALS, but my wife likes to give a report to every therapist we see at clinic. So I think his wife is keeping a good eye on him, it sounds like.
Yeah. Thank you to his wife.
Yes. And sometimes it's helpful because when you go to clinic and see a lot of different people in one visit or one time, sometimes it's helpful to have someone else there just to take notes or make sure that you're reporting everything that's gone on the past several months or since you were last at clinic.
Yes, absolutely. The support system is everything.
So I would invite again anyone that has questions or comments, please enter them into the chat box. We've had a number of questions and a couple of comments come through. Again, this entire webinar will be recorded for your convenience. It takes about 24 hours to get that on our website, and you'll be able to view the entire webinar, hear the recording, and also open up the associated slide deck. So are there any other questions or comments that people would like to submit? Yes, someone has just shared with us a comment about medication. Some of the medication that has been prescribed has been denied by someone's insurance. They're sharing that they want a slow vital capacity, but the clinic is only providing a forced vital capacity. Lauren, can you share the difference between the SVC and the FVC and share how someone can request their clinic do the slow vital capacity?
Yes, this is you're not alone here. This is something that we encounter all the time. So the reason that they're requesting the insurance is requesting a slow vital capacity for approval of a drug is because they went back to the criteria of what patients were included in the study. And the study used a slow vital capacity of patients greater than 50% or whatever it was. So the insurance sees that and they want a slow vital capacity rather than a forced vital capacity. There is little to no difference in this measurement unless you have a lot of bulbar involvement, so involvement of the speech and swallowing muscles. The primary difference is the direction that's given when you perform the task. So for a forced vital capacity, you take a deep breath in and you blow out as hard and as fast as you can for as long as you can. If you have difficulty with your speech and swallowing muscles or the muscles of your upper airway, breathing out really forcefully and quickly can cause the upper airway to collapse and it cuts off the air. So in those patients, we use a slow vital capacity where the direction is take a deep breath in and blow out for as long as you possibly can, but it leaves off the direction of making it forceful. So it just gives us the ability to avoid that forceful breath out that typically results in collapse of the upper airway, but still gives us the measurement of how much lung volume is there for that person. So the difference in the task is very little. But sometimes, for instance, if you have a lot of bulbar involvement, your slow vital capacity measurement can be much greater than your forced vital capacity measurement because of the nature of the task and the involvement of the upper airway. But insurance companies just really like to create a barrier for all of these drug approvals, especially with the newer ones that have been approved, the oral Radicava, the Relivrio. These are issues and obstacles that all clinics are facing, unfortunately. And this is another reason, kind of going back to the multidisciplinary care. If you're putting all of these obstacles on a single neurologist, it's going to be very difficult for them to get these drugs approved. But in any other clinic, you have the neurologist, a nurse practitioner, a patient care coordinator, as well as sometimes an additional just RN that can really help get this paperwork done, get things signed, do face-to-face evaluations with the assurance company to try to overcome some of these obstacles and get the drug approved.
You know, it's quite helpful to have that team, particularly when something is prescribed and then there is a denial or additional information is requested, to have that team that can respond. So you're saying with respect to the forced vital capacity and the slow vital capacity, essentially the same person, the respiratory therapist, performs both of those tests with essentially the same equipment, and it takes about the same amount of time. So it's not a separate test that somebody has to go out and schedule separately.
Correct. The respiratory therapist can do both of these tests. The reason that we don't do both in clinic typically, like we don't do a slow and a forced vital capacity, is because it's so effortful and it's a maximum effort task that it's just exhausting. It's really hard to get a sitting FVC and SVC and then a laying down SVC and FVC and really have it be your maximum. You know, you're going to be exhausted by the time those measurements are over. So most clinics do either one or the other.
Wonderful. Thanks so much for that overview. We have a couple of comments that people do appreciate the details you're providing about the clinic overall, and then specifically about some of the specific tests. So I would invite anyone else to submit questions or comments to the chat box. Okay. Quite an overview. We talked about research. We talked about the potential for telehealth, if that is appropriate for people or if that's available in their clinic. The value of having the entire team there, both if you have multiple challenges or even if your challenges seem to be limited at this point in time. I do not see any additional questions or comments. We are just a few minutes ahead of time. I do want to be respectful of everyone's time. I know time is valuable, particularly beautiful afternoon. I'd like to thank everyone for joining us and invite you to join us again in February, where we're going to be hearing about palliative care and mindfulness through your multidisciplinary clinic. I'll give you a call. One last call for questions. And I see we're complete. Dr. Tabor Gray, thank you so much for your time this afternoon. Again, the recorded webinar and associated slide decks will be on the als.org website. Please give us about 24 hours to post those. Thanks so much and have a great afternoon.
Thank you all.